Respiratory system, lung fibrosis, upper zones, HSV pneumonitis, coal workers pneumonitis, silicosis, sarcoidosis, ankylosing spondylosis, histiocytosis, TB, cystic fibrosis. तो यहाँ पे TB like things are in the upper zones obviously, and only one CTD is there, that is Angst-Pons. लोअर जोन्स में इडियोपैथिक पल्मोनरी फाइब्रोसिस, कनेक्टिव टिश्यू, SLE, drugs like amiodarone, bleomycin and methotrexate, and asbestosis. COPD, more than 35 years of smoking and no smokers with exertional dyspnea. Emphysema with chronic bronchitis, more than 3 cough for 2 years, 3 months of cough for 2 years. So investigation, you do post bronchodilator spirometry in the FEV1 by FVC ratio, which is less than 70%, and chest X-ray hyperinflammation of the bullae, flat hemidiaphragm, and full blood count excluding secondary polycythemia. BMI, type 2 respiratory failure, इंक्रीज इन द PCO2, रेस्पिरेटरी एसिडोसिस होता है. पोस्ट ब्रोंकेक्टासिस, FEV1 बाय FVC अगर आप करोगे तो लेस देन 0.7 रहना चाहिए. एंड FEV1 प्रिडिक्टेड अगर मोर देन 80% है तो ये स्टेज 1 है, 50 to 79% है तो स्टेज 2 मॉडरेट, 30 to 49 is stage 3, and less than 30% is stage 4 very severe. Measuring peak expiratory flow is of limited value, as it may underestimate degree of airflow obstruction. Then treatment of choice, 15 hours of supplement per day, FEV1 less than 30%, consider in 30 to 49%. Cyanosis, polycythemia, peripheral edema, increased JVP, oxygen 92%. COPD के causes है स्मोकिंग, अल्फा-1 एंटीट्रिप्सिन डेफिशिएंसी, कैडमियम, कोल, कॉटन, सीमेंट एंड ग्रेन. ठीक है, तो स्मोकिंग, अल्फा-1 एंटीट्रिप्सिन डेफिशिएंसी, कैडमियम, कोल, कॉटन, सीमेंट एंड ग्रेन कैन कॉज COPD. Now when after assessing for the long-term oxygen therapy treatment, that is you give 15 hours of the supplement per day and FEV1 is less than 30%, cyanosis is there, polycythemia is there, peripheral edema is there, increased JVP, and oxygen is 92%. ABG is done by measuring the ABG on 2 occasions at least 3 weeks apart, and with stable COPD. PO2 should be less than 7.3 kilopascals or 7.3 to 8 with secondary polycythemia, peripheral edema and pulmonary hypertension. Now initial ventilator settings, IPAP is 10, EPAP is 5 centimeter of water. Acute exacerbations are due to, most common is H influenza, Streptococcus pneumonia, Moraxella catarrhalis, RSV in 30%. Then do not offer long-term oxygen therapy to patients who continue to smoke. Oxygen therapy, PO2 of 8 kilopascals, 60 millimeter mercury पे देते हैं. Treatment, smoking cessation, ठीक है. Then annual influenza vaccine and one-off pneumococcal vaccination. Pulmonary rehabilitation of more than MRC3, bronchodilator, SABA or SAMA first line. Treatment अगर asthmatic features है which are suggestive of COPD, then previous diagnosis of what are the asthmatic features, previous diagnosis or atopy, increase in the blood eosinophilia, substantial variation in the FEV1 for 400 ml, substantial variation in PEFR at least 20%. ठीक है, अगर ये रहा then you will give long acting beta agonist with inhaled corticosteroids. If this is not working, you add long acting MA So long acting muscarinic antagonist and long acting beta agonist plus ICS, then you can, if this is not working, you can switch the SAMA to SABA. ठीक है. Then if the patient does not have asthmatic features, then long acting beta agonist with long acting muscarinic antagonist and SAMA to SABA. If this is still not working, then in the end you add inhaled corticosteroids. ठीक है. यहाँ पे you will treat it like SABA only, like asthma only. Now oral theophylline, decrease dose of macrolide or fluoroquinol. Then prophylactic antibiotic treatment, azithromycin, CT, sputum culture, LFT, exclude QT, and increasing in macrolide. Okay. Then mucolytic chronic productive cough, cor pulmonale, peripheral edema, increase in the JVP, systolic parasternal heave, and loud P2. Treatment: loop diuretic, LTOT, ACE inhibitor, CCB, alpha blocker, not recommended. ठीक है.